For an AP projection of the hip, immediately rotate the lower limb and the foot approximately 15 to 20 degrees to place the femoral neck parallel with the plane of the IR. Direct the central ray perpendicular to the femoral neck. The top of the IR should be placed approximately at the level of the as-is. Be sure to suspend respiration prior to taking the exposure. When evaluating the image, in addition to the entire hip joint, the greater trochanter should be seen in profile. Any orthopedic appliance should always be seen in its entirety, and also ensure that the entire long axis of the femoral neck is not foreshortened. This next projection is known as the Cleaves method. Do take note that although this is an oblique projection, many of the clinical facilities often use this as their lateral projection of the hip. To obtain this position, adjust the body position to center the as-is of the affected side to the midline of the grid. Have the patient flex the hip and knee of the affected side and draw the foot up to the opposite knee as much as possible. After adjusting the perpendicular central ray and positioning the IR tray, have the patient brace the sole of their foot against the opposite knee and abduct the thigh laterally, approximately 45 degrees. The pelvis may rotate slightly in this position. Suspend respiration and direct the central ray perpendicular to the IR. This is an example of an image obtained by doing the Cleaves method. Compare this to the next method that we see in the Lonstein-Hickey method. One thing you may notice from this image is the foreshortening seen in the femur. This is due to the fact that the knee is elevated from the table. When performing the Lonstein projection or the lateral projection of the hip, the major difference between the modified Cleaves is that this patient is going to be rotated slightly or oblique towards the affected side. The degree of obliquity will depend on how much the patient can abduct the leg. For this, ask the patient to flex the affected knee and draw the thigh up into a position nearly at a right angle of the hip bone. When rotating the patient, make sure that there is no superimposition of the unaffected side over the affected side. And as a reminder, direct the central ray perpendicular through the hip joint. This is located midway between the as-is and the pubic symphysis. The resulting image shows a true lateral projection of the hip, including the acetabulum, the proximal end of the femur, and the relationship between the femoral head and the acetabulum. On a side note, one thing I'd like to mention is that the Cleaves, which is often used in the clinical setting for the lateral projection, is also known as the unilateral frog leg.